the left leg. If it were weak, the right leg would sag. It's not strong enough to hold up the hip. Okay, that looks good. On the other side, please. So then we're checking the glute medius of the standing leg. If it were weak, the left leg would sag. Does that make sense? Alrighty. You can do Adams. Before we start, you just want to observe the patient's spine. You might notice a structural deformity. You can look for scoliosis, muscle tension, anything abnormal. Go ahead and bend forward. Try and touch your toes. You can also, again, observe. You at least want to observe. You can palpate in reality, just checking tonicity on each side to see if anything's changed. That's good. And then we can do Kemp's. You learn this another way. You can do it either way. If you want to go ahead and run your hand down the back of your leg. Any discomfort there? Nope. Same thing on the other side. So you can do Kemp's sitting, which is the way that you learned it, or you can do it standing. Doesn't matter. We just wanted to show you both. Okay. Go ahead and have a seat for me. And then we'll start with vectorus. So stretch one leg out, and the other leg, and both. Making sure he doesn't lean back. I'll come back and we'll do compression and distraction. So interlace your fingers. I'm going to press down on your head. Let me know if anything's uncomfortable. Okay. And when we distract, we use the hypofenar eminences on the occiput, remember. Good. We can do shoulder depression from here. Just relax. Comfortable. Good. We can do Adsons and rights. So Adsons, radial pulse, baseline. Turn your head to the right one. Checking to see that the radial pulse does not decrease and into the left. Reverse. Decrease there. And then for rights, we're going to hyperextend and abduct the arm. Just get a radial baseline. Turn your head to the right one. Good. And to the left. Decrease. Good. All right. And then you would do it obviously on the other arm as well. So you can clear it. And now I'll have you go ahead and lie back. So we'll start with straight leg raiser. Just remember to keep your hand on the knee to keep the leg straight as you raise it. Up until he says youch, or you get resistance, which might be tight hamstrings. He's pretty flexible. So ouch, that hurts. I'm sorry. I'll just lower that a little bit. How's that feel? Then I'll dorsiflex the foot for braggarts to see if that elicits pain. No, he's good. You can do Koenigs. Hip and knee are at 90 degrees. Stabilize the knee, and you're going to extend one more time just to see if that elicits any pain. Good. Thomas's. Go ahead and bring the knee into the chest. You can come down over the knee for support. You're looking at the opposite hip to see if it comes off the table for a flexion contraction or tight hip flexors. And then lastly, Patrick Fabre. One hand on the knee, the other on the opposite SIS, and press. And then I'll just repeat on the other side for you guys. So, straight leg raiser, hand on the knee, all the way up. Ouch, so sorry. Is that good, better? Yes. All right.
Your accent, too.
Dorsiflexion. This is braggarts. No pain. So then we can try Koenigs. Hips at 90 degrees, knees at 90 degrees. I'll support the knee while I'll extend again. Good. And we'll do Thomas's, knee into the chest. And I'm looking at the hip to see if it's coming off the table. Patrick Fabre. One hand on the knee, hand on the opposite ASIS, and press. And last but not least, Soto Hall. So, just going to passively flex their head while you stabilize the sternum. So if there's any discomfort. Good. Gentlemen, just be aware, women with breasts, you probably don't want your hand down this way. Just keep it to the side or up towards their, facing towards their chin. Can you flip over on your side? And we'll do Akalas. So ipsilateral buttock. Looking for radiating pain to the anterior thigh would be like an L2, 3, 4 lesion. Eli's, contralateral buttock. Hips, you can stabilize the sacrum with your hand as you bring the foot out to internally rotate the knee. And yeoman, his legs are big, so I'm going to put his hand underneath mine. Stabilize the knee, hand on the ipsilateral sacral region while you lift. You can do that one extra times. Shall we do that on the other side? You got it? Okay. Any questions on the spine? Good. There's our row. All right, legs.
All right.
Shoes come off. Let's go. So we start with observation one more time. I'm just observing his position, looking for any joint deformity motion, asymmetry, looks good. Again, you can do gait analysis because for practical testing, you'll either get spine or the leg, and you'll want to assess gait for both. So could you just go ahead and walk the testing? You can do heel walk, toe walk, and tandem walk as well. Excellent. And then we'll just do active range of motion. So we're going to start with the hips. So go ahead and flex your hip for me. Bring your leg back. You don't want your patient to lean forward really. I'm sorry, I keep leaning too. You want them to stay upright and just extend their leg as far back as they can. Bring your leg back down, toes out for external rotation, toes in for internal rotation. Good. We're going to abduct leg, bring the leg out, and in and across. Good. And then we can bend the knee, and straighten the leg. Feet up towards the ceiling, point the foot. Keep the foot pointed but flex the toes. Excellent. Point the toes one more time. Bring the sole of the foot inside and then turn the foot out for inversion and eversion. We'll do the same thing on the other side. Bend your leg. Good. Straighten your leg and bring it back as far as you can. Good. Up. Toes out. Toes in. Good. Leg out to the side. Good. And back and across. Good. Now bend your knee. And straighten your leg. Foot up to the ceiling. Point your foot. Keep the foot pointed, but flex your toes. Point your toes. Sole of the foot in and out. Good. Any questions over that? Okay. We'll do muscle testing. So go ahead and see. For most of this, like the upper extremity, you can do it all at once, except for the hip flexors and extensors. It's really hard for someone to lift both their legs at the same time, so you kind of have to do one. And toes. You should probably do this by themselves. So we'll do this on the other side too. Lift against me. Great. Lift up. Now lift your leg. Press down. Okay. One more time. Okay. Press out towards me. Good. Against me. Good. Lift your feet up. Good. Press down against my feet. Okay. To do the toes, I just stabilize the foot so the ankle's not involved. Press down against me and up. Good. Same. Down and up. For inversion and eversion, I put his foot into position and have him hold it. And I'm going to try and move your foot. Don't let. Good. Move foot out. Hold. Good. Hold here. Okay. And one more time. And hold. Good. And good. That's that. So we should put that on the shoulder. All right. So press up against my hand. Good. One more time. Lift your leg. Press down. Press down. Press forward towards me. Pull back. Okay. Press your feet up against me. Press down against my hand. And then I just stabilize the foot. Toes against my hand. Press down and up. Good. Press down and up. Just forget this foot. Press down and in. That's it.
And the first one.
Oh yeah. Inversion. So hold here. Don't move your foot. Good. Invert. Goodness. Hold. Good. And out. And hold. Okay. Any questions? All right. So we can do orthopedic testing. So you can go ahead and lie down on your back. I'll repeat Thomas and Patrick for break because they're part of the leg as well. So if you just have leg, you want to do those again. So we did the chest. And I'm looking at the opposite hip to see if it's coming off the table. Break. Hand on the knee. One hand on the opposite ASIS. Then we can assess the knee. So varus and valgus. Again, varus will bring the upper part of the lower extremity towards the knee, and that checks the medial collateral ligament. The lateral. And valgus is pressing the upper part of the extremity that way, and the tibia towards me, and we're checking the medial collateral ligament. You can do anterior and posterior door. So the hip should be at 45 degrees, the knee should be at 90. You can sit on the foot. Make sure that your hand's a little bit under the tibia, not directly on the joint line of the knee, and you're pulling anteriorly to check the ACL, posteriorly to check the PCL. Lockman and reverse Lockman is essentially the same, except the knee's at a 30-degree angle. You don't have to sit on the foot, but I'm going to. I hold my hands the same way and pull anteriorly to check the ACL and posteriorly to check the PCL, but you may have known Dr. Nick teaches you a different way, and that's acceptable for you to use that hand positioning. That's okay. long as you're just testing the ACL and the PCL appropriately, I don't mind. Okay. Murray. Bring the leg up. You're going to externally rotate the knee. The foot should always be in the opposite direction of the knee. So if the knee is externally rotated, the foot's internally rotated. Hips at 90 degrees, knees at 90 degrees. And we're going to follow through until we straighten out the leg. And then we repeat with internal rotation of the knee, external rotation of the foot, and follow through. You're looking for a click to indicate a meniscal injury. Do you need to see that on the other leg?
Sure.
So external rotation of the knee, internal rotation of the foot, and we'll just follow through until we straighten out the leg. Knee is 90, hip is 90, internal rotation of the knee, external rotation of the foot, follow through until we straighten out, okay? Okay, patellar grinding test. So you're going to push the patella down into the trochlear groove and move it laterally and medially to check for any pain. This is for convermalacia patella. Clark's test, same thing. Push the patella into the trochlear groove and have the patient flex their quad. Great. Patellar apprehension test. I'm just moving so you can see. You're just literally pushing the patella laterally to the side to check for potential dislocation or prior dislocation. And the bounce home test. Stabilize the foot. I'm going to lift your knee. I'm going to bend your knee. Just keep it relaxed for me, okay? And let go. You're checking for end feel, rubber infield, pain, swelling, any meniscal tears there. The last thing we have to do is ankle, anterior, and posterior drawer. They're named for the way the calcaneus is moving. So for anterior drawer, the calcaneus is coming anteriorly and vice versa. So you just want to stabilize the joint. One hand on the tibia, one hand on the calcaneus. The anterior drawer, you're going to pull anteriorly. Right? And then for the posterior drawer, just switch your hands and push the calcaneus posteriorly. And back to your seat. And then I'll have you flip over. And we'll do Apley's compression and distractions. Your leg for compression. I'm going to make sure that you have your hand around the ankle joint. You press down to the floor, and you're rotating the tibia both ways. And then for distraction, you need to bring your leg up and stabilize the patient's thigh. Hold a little above the malleoli. Lift, and again, rotate the tibia. So, the compression checks for the menisci, and the distraction checks for the lateral ligaments. And the medial ligaments. There, now we're... Any questions? Okay. Well, I'm going to cut you loose to practice, and we'll be around to show you